really honored to be moderating today's program, which is the last in our three-part series on COVID vaccines and other countermeasures and the future of pandemics. So last week, the United Nations Secretary General Antonio Guterres said that equity in distribution of COVID vaccines is, quote, the biggest moral test before the global community. So far, it appears that the world is failing that test. Guterres noted that just 10 countries around the world have so far administered 3/4 of all the vaccinations for COVID given out to date. And this situation has left 130 countries without a single dose to administer, a wildly uneven and unfair distribution of vaccines, Guterres said. On top of the global maldistribution of vaccines, there's inequitable vaccine distribution and access within countries, including the United States. Only about 1 in 3 US states actually reports vaccination data by race. But based on that data, vaccinations among Blacks and Latinos as of mid-January were proportionally far lower than those populations' actual shares of COVID cases and deaths. So clear demonstration of inequity there. Within countries such as our own or among countries, equitable distribution of COVID-19 vaccines is a huge and so far unmet challenge. And while important efforts have been undertaken to produce vaccines for poor countries and to get those vaccines to them, it's unclear at this point how well those efforts are going to succeed. So what are the underlying drivers of inequitable vaccine distribution? And what are the most promising efforts and strategies to address that problem? Our distinguished panelists today are going to take on those questions, so let me introduce them now. First, we're delighted to have with us Dr. Lisa V. Adams, who's a graduate of the Geisel School of Medicine and is director of the Center for Global Health Equity, as well as Associate Dean for Global Health at Geisel and at Dartmouth. As a global health expert, she's been involved for many years in a research collaboration between Geisel and Muhimbili University in Tanzania, focused on tuberculosis and HIV. In particular, she helped to lead a clinical trial of a new TB vaccine candidate there. Closer to home, for the past year, she's been co-chairing Dartmouth's own COVID-19 task force, which has been monitoring the current vaccine rollout process in both New Hampshire and Vermont. We're also very happy to have with us Dr. Agnes Binawaho, who's the Vice Chancellor of the University of Global Health Equity in Rwanda, an adjunct clinical professor of pediatrics at the Geisel School of Medicine. Beginning in 2002, she led Rwanda's National AIDS Control Commission, and then she went on to serve as the country's Minister of Health, from 2011 to 2016. In those roles, she was a key architect of Rwanda's national health system, which was reestablished in modern form in 2008. The strength of that system is a key reason that Rwanda has met with considerable success in fighting COVID-19, with a substantially lower case count and mortality rate compared to many other African nations. So we're delighted to have Dr. Agnes, as she is frequently known, here with us today. We also welcome Niranjan Bose, who earned his PhD in biochemistry at Geisel in 2004, and also the Business Bridge Diploma from the Tuck School at Dartmouth. He's the Managing Director for Health and Life Sciences Strategy at Gates Ventures, LLC, where he serves as the science advisor to Bill Gates Jr. Prior to joining Gates Ventures in 2014, he was chief of staff to the president of the Global Health Program at the Bill and Melinda Gates Foundation. And we welcome Christopher Snyder, who is the Joel Z. and Susan Hyatt Professor of Economics at Dartmouth. He specializes in the fields of industrial organization, law and economics, and microeconomic theory. He's also become very involved in work around economic incentives to speed vaccine development, which, as we heard in our translational medicines discussion last week, is notoriously underfunded due to relatively low return on investment. Recently, Chris and colleagues have advocated for special strategies to pool investment funds in advance to pay for vaccines. He's also been involved in the work of COVAX. That's an organization led by the World Health Organization and other key groups whose aim is to accelerate development and production of COVID-19 vaccines and to guarantee free and equitable access for every country in the world. And we'll hear more about COVAX later. Before we get started, I wanted to run through a couple of housekeeping items. First of all, we want this session to be very interactive, and we'll do our best to respond to as many questions as possible. Please submit those through the Q&A button, which is at the bottom of your webinar window. If you see a question that you're interested in, please go ahead and upvote it so it rises to the top. Please also use the chat box for any technical challenges you might experience during today's program. The webinar is being recorded. We'll make that available to everybody who attended after today's session. And last of all, you'll be receiving a survey at the conclusion of the program. Please do take a brief moment to complete that survey and provide us your feedback. It will help us as we plan future programming. Now, to kick off today's discussion, I want to start with a poll for all of our attendees. Here's the question now. Do you think that the vaccine is being distributed equitably, and I should say the vaccines are being distributed equitably within the US and across the globe? And you see your choices there. Definitely yes, mostly yes, not sure, mostly no, definitely no. I agree with Antonio Guterres. Your choices there. Please go ahead and select one. We'll do these computations and see where we come out in just a moment here. Okay, so actually we have a couple of people who say mostly yes, a few more who said not sure, a lot of more mostly no's, and a lot more definitely no's. So as we see a little bit of a difference of opinion, we'll see what everybody thinks when we finish up our webinar here today. So Lisa, I want to go first to you. Besides the obvious difference that rich countries have much more in the way of financial resources to pay for vaccines than do poor countries, and there are huge wealth inequities even within countries like the United States, what would you say are some of the other factors that are driving vaccine inequities around the world?
Thank you, Susan, for that question. And I have to begin by saying, as someone who's devoted my professional life to promoting health equity, I am so pleased to see this topic being discussed today and more broadly gaining what I think is long overdue public attention. So a recurring refrain, if you've been following this issue, is the recognition that no one is safe until we all are safe. If this pandemic has taught us anything, it's that we are part of a global community. And so the first barrier to overcome is any concepts of vaccine nationalism. Ensuring vaccine access in all countries and communities is a matter not only of fairness, but infectious disease epidemiology tells us it's the only way for us to eventually control this pandemic. And of course, it's important, as you say, that we aim to distribute vaccines equitably, not only to all countries, but also within all countries. So equitable distribution of vaccines does require some critical elements. So first, there has to be a stable and sufficient healthcare and public health infrastructure to deliver vaccines in terms of things like distribution and transportation systems, facilities to store vaccines, and then the healthcare personnel to take those vaccines doses into arms. But a second critical and often underappreciated element is trust in the public health system to deliver a safe and effective vaccine. We know that national responses to this pandemic have revealed underlying cracks in our healthcare delivery system, as you mentioned, and these have exposed long-standing disparities. And this has certainly been the case in the US, as we have seen the disease burden and mortality rates among people of color far exceed those among whites. Now, we know that many low and middle income countries have healthcare systems that are stretched under normal non-pandemic times, and that they suffer some dramatic healthcare worker shortages, with some countries having only 1/10 of the basic threshold for skilled healthcare personnel. So this is going to pose challenges to vaccine access both for and within countries, especially when we think about underserved rural areas which may present the last mile for vaccine delivery. However, while the gaps in low and middle income countries are significant and need to be addressed, this dialogue shouldn't be all about deficits. So I ask you to consider this notion, that some healthcare systems in low and middle income countries are actually ahead of some high income countries in creating more equitable distribution of vaccines within their borders. And this has to do with the who these countries have engaged in their healthcare workforce. Many African nations have employed community health workers, for example, individuals who are from the community and are trusted by the community to address local health needs, including vaccine delivery. And frankly, we in the US can learn a lot from countries like Rwanda, a place where I've worked for many years, and where their extensive community health worker network helps extend the healthcare system into all corners of the country, and where they have already prioritized delivering care to the most vulnerable. So while the backdrop of current healthcare systems challenges in these countries can lead to challenges in vaccine allocation, there are also particular strengths that we should simultaneously acknowledge in a more nuanced understanding rather than a stereotypical reflexive response to focus only on the gaps in these settings.
Great points, Lisa, and a terrific segue to Dr. Agnes in Rwanda, where, as I mentioned, with a very strong basic infrastructure in its health system, Rwanda's been able to do better than many countries in combating the pandemic. What is the situation, Dr. Agnes, with respect to access to vaccines now in Rwanda and distribution of vaccines in Rwanda?
So we have started, thank you, Suzanne, first of all, for your warm introduction and welcome, and hello to everybody. We have started receiving few vaccines that has been distributed according to the national plan, meaning too few. And for the distribution, we are ready, even for this Pfizer diabolic vaccine that need a temperature that I even cannot imagine. We are ready. We have created an infrastructure to store them and a national plan to deliver them. And so the vaccine we receive went first to the health professionals, but we have a national plan where it's health professionals. When I say professionals, is healthcare providers, because as Lisa says, we use the community health workers and they have to be protected as much as doctors and others. And after that, we have elderly people live in place where there are where there is a high risk of contamination. And this means prisons, refugee camp. And we have, and people with pre-existing conditions that are reported. So we have a plan. We have received the vaccine and they have been given immediately. We are waiting for the next branch. But as you say, Rwanda, like many countries, are left out of the global distribution and underserved, and the Western nationalism has a big to do with that. So many countries, and your country didn't, but your country now just signed for COVAX, agreed that health professionals had to be vaccinated. Healthcare providers have to be vaccinated first as the people on the front line at risk. And before anything, vaccine nationalism alone has taken over, and you have seen governments sign parallel agreements, and some of them even going up to not allowing a country like ours to buy if we have money. So you have seen that COVID is a great opportunity for global health equity, solidarity, and change of mindset. However, we are missing the point. And if countries like mine have done well, because today we have only less than 18,000 cases and less than 250 deaths because we have managed the spread. We have created a system to protect the community and the people living on the territory against the vaccine. We may face problem with time because if things are going as they are going now, access to vaccine for continent like mine will be in 2022, 2023. However, variant will come from here and will kill the world. So we need to change that. And a way to change that is reflect and help producer of vaccine factories to decentralize, to keep the intellectual property, we don't care, but increase the production and the distribution and everywhere, and especially don't put the failure to be vaccinated on vaccine hesitancy. It's more on global health criminality because we know what happened. We know that it killed. We know that we should all come together and distribute vaccine differently to save the world. We are not. So this is my view, but what is there is dramatic. And it reminded me what happened in the year 18 with HIV. You remember? We were too poor, illiterated to receive ARVs. And there is not enough for the world. And if we take it badly, we are going to create resistance. And it was not the case. We are not stupid. We want to live. We want the world to live. And we need solidarity for that and applying the lesson we know. Nationalism is the worst thing that can happen with this pandemic.
Well, thank you so much, Dr. Agnes, for making those very, very powerful points. And we want to come back and ask you more later about specific avenues that Rwanda is taking to procure the vaccines at this point. Chris, though, let's move to you and stay on the overall global context of vaccine distribution. Antonio Guterres proposed creating an emergency task force of the group of 20 richest countries to prepare and implement a global immunization plan. And as an economist, you're obviously familiar with issues of supply and demand. So let's talk about vaccine supply and your work with COVAX to help create that supply and distribute it equitably. How could we build on that work now to have a truly effective global immunization plan?
Just to expand on a point Dr. Agnes mentioned, and it's a lack of supply. It's it's not vaccine hesitancy, but it's you need the courses there to distribute. We have an incredible shortage. We'd love there to be 7 billion courses, or however many. We may not be vaccinating children, but we'd love there to be 6 billion courses to distribute immediately to the world. The capacity is just not there to supply that much vaccine. So sure, our capacity might dribble out vaccine that will arrive at, especially low-income countries 1, 2, 3 years from now. But of course, that's not a very valuable vaccine because all of the economic and health losses are being suffered in the meanwhile. So this is unlike most situations in a pandemic. Speed is of the essence, and large capacity is what delivers, manufacturing capacity is which delivers speed, because you can roll that vaccine out and distribute it. Well, we just don't have it. It's very scarce. It's too bad. It's you mentioned this COVAX facility. It was devised back in last May, and they were thinking let's fund capacity, let's get it scaled up. It just had trouble coordinating the world on this international agreement. And so then we went to bilateral contracts between manufacturers and countries. And it was the rich countries, the US and other rich countries that led on that. But even there, to my mind, we underinvested in capacity there. Did some estimates, the value of capacity that would have been built back then that could maybe produce stockpiles or been online running now. It basically, you can compute it as something like $2,000, $3,000, $4,000, $5,000 per course in terms of avoided mortality harms and economic output losses. But there it is, we're here today, and the question is, okay, so we didn't invest as much as we should have, either bilaterally or as an international agreement. So what is it too late now? What can we do now? So that's a great question. We do have some capacity online. We've done some analysis, and it suggests that even though capacity takes time to come online, even if there were, say, 6-month lag to come online, it's worth making these investments. And it's actually worth, if middle and low income countries could afford to do it themselves, it's actually worth, the World Bank is offering some loans to do some of these purchases, to actually do these purchases. And even though the doses could be somewhat expensive, it's still worth it. Of course, it would be better for the world to come together and, say, expand COVAX and do some of this funding, on behalf of poor countries. I think part of the problem is, I think maybe poor countries are waiting for the world to come through with COVAX. That's not, it seems like we're not getting that scaled up. So then the poor countries are sort of waiting, saying, well, this might happen. I think we need some coordination, and hopefully COVAX will perform that function now. It didn't really scale up as quickly back in May as it could have, but maybe going forward now it could. So basically speed is of the essence. It's not too late to actually expand the capacity that we have. It's worth it. I don't see rich countries donating the scarce doses that they have now, but certainly it's worth them putting in whatever money is needed to fund, even if it's fairly expensive, the manufacturing capacity needed to serve poor countries. Basically, a billion doses, annual courses of capacity, we can basically would cut down time to complete vaccination in the world by, say, 10 months. And so this is money well spending for rich countries.
And as we know, initially the U.S. decided to stay out of COVAX under the prior administration, partly because of the link to the World Health Organization. But that decision has now been reversed. And President Biden said over the weekend, the U.S. will now support COVAX. Is that going to, in your view, lead to greater commitments from other rich countries to really move forward to expand the capacity in the way you described?
I hope so. I think that's, I think it was a $2 billion commitment, which is a nice start, and hopefully other rich countries will contribute. But that's as people are saying, that's money. That's pennies on the dollar to avoid the externality of the disease, of course, coming back just for the selfish reasons of the disease coming back in different strains to rich countries. But of course, that's not the only reason to do it. We're altruistic, we're humanitarian, and so much economic and mortality losses can be avoided. So certainly.
Great. Well, thank you, Chris. And Niranjan, let's go to you and stay on this theme of distributing vaccines within poorer countries, the demand side of the equation. Lisa talked a bit about that earlier, everything that one needs in place, from supply chain, from personnel to administer the vaccine, et cetera. What other factors do you see as being most relevant as we think about getting these vaccines out and into arms, shots in arms in other countries in particular?
Well, first off, good morning, Susan. Good morning, all. Thanks for having me here. It's great to be part of this panel. I want to start by acknowledging a few things. Post the Ebola crisis, the standing up of CEPI, I think, was a phenomenal game changer, which is helping us now in this pandemic. Likewise, Chris's point, COVAX and the COVAX AMC have been, has the potential to be a game changer, but are in referencing the Secretary General and also what Dr. Agnes said, but have we taken an equitable approach to how the vaccine should be allocated and distributed and administered? I think the global leadership has failed in that, and hopefully the COVAX and the COVAX AMC will have an opportunity to course correct. In terms of demand, I want to go back to what Dr. Agnes said. These countries have tremendous experience of building confidence, community outreach, they are well prepared when it comes to administering routine vaccines and even campaign vaccines, polio eradication programs, measles campaigns. So the understanding is there, the willingness is there. With these vaccines, I think there's going to be a little bit more preparedness that needs to be thought through, because not all of these vaccines come in the same sort of equal manner. Some come in 6 doses, some come in 10 doses. It's 0.3 milliliters administration versus 0.5 milliliters administration. One has a diluent, one doesn't have a diluent. So it's not going to be a one size fits all. So preparedness, when these vaccines arrive, I think there has to be a very thoughtful micro planning that goes into how are we going to administer these vaccines. So that's one element. I think the second element is use the community outreach and the confidence building that's happened to be prepared for administering the vaccines. Wastage becomes a key factor here, because once you open the vial, you need to administer all doses. So knowing what your catchment area is going to be and how you're going to administer that, these countries have tremendous experience doing that. And I might even say much better than the US, if I might argue, in their preparedness. So those are the two pieces I would think through. How are we going to hit the last mile delivery, and how are we going to be prepared in building the trust and confidence?
As countries begin to do that, are there notable examples, again, of countries that are, as is the case with Rwanda, doing a better job than others that can offer some lessons learned to other nations? Ranjan.
I absolutely think so. I mean, Rwanda, when it comes to vaccine delivery, for that matter, when it comes to maternal, neonatal, child health, and health outcomes, is an outlier, a positive outlier by many stretch, many indications. But there are other countries too. For instance, Zambia has done well when it comes to vaccine delivery and vaccine coverage. So I think there is an opportunity to learn from some of these countries, how they've gone about. There is a distinction to be made between routine immunization, which is the EPI vaccines, and the COVID vaccine, but it's not something that cannot be bridged. Absolutely very doable, learning from EPI as well as other campaigns. As you look at some of the countries that have done well now, I think the global outlier is Israel in terms of how they've been able to ramp up vaccine coverage. And there could be lessons from rich world countries too that we should be able to adopt and embrace.
I want to come back and ask Dr. Agnes one additional question before we go to audience questions. Dr. Agnes, China has made a lot of noises now about making its vaccine available to other countries, as has Russia. Do you believe that countries like Rwanda or others elsewhere will be taking them up on all the offers of vaccines at this point?
100%. You know, those vaccines are not dangerous, first. Second, apparently, Sputnik, is it Sputnik? Huh? Yeah, is as efficient as Pfizer, if not a little bit more. The third, the Chinese one, the efficiency is okay. Those people say 50%, others say 70-something%. But what happened with even 50%? You don't do severe, you don't have severe symptoms. You don't need a respirator. You don't need oxygen. Everything we miss here. Okay? So remember also CDC Atlanta, less than 18 months ago, with at that time the flu vaccine that was efficient at 50%. What CDC Atlanta said to all, vaccinate yourself because the best prevention is a vaccine. Now, those vaccines are not for a long period. If I will get the 5-star vaccine in 3 years from now, just give me the Chinese one.
Mm-hmm. Yep. Well, that's fascinating. We'll see a really interesting set of dynamics play out in that regard in the coming months.
The issue here, Suzanne, there are some parts of the world who have made mask a politic tool. Please, the world, don't make vaccine a politic tool. And it's coming now to make a politic tool. When you see that we have a man called Putin, who is so proud to give their vaccine to their political enemy who are fighting against them with European Union because European Union neglect them. And the only thing that people see is European Union, not the people who are saved. You see, death cannot be a political tool when it's preventable.
Great. Well, we're going to go to the audience questions now. Thank you, all of you. We have a question that is come in about what it would take to actually develop a wider manufacturing base to produce more localized sources of vaccines and other medical therapeutics. And Niranjan, I want to direct that first to you. Do you have a sense that these localized production plans are in fact going to be developed, and what would it take to make them possible?
Yeah, great question. And I think I take it in two parts. One is near term, to stand up a vaccine manufacturing facility with good manufacturing practices, GMP, and to deliver at scale. It's going to take time. This is not something we can stand up in a matter of weeks or even a couple of months. However, in the mid to long term, I think we should be thinking about a hub and a spoke type model. Could you manufacture the bulk vaccine and have it finished in a facility that's a spoke? I mean, these are concepts that will absolutely have to emerge as part of the global preparedness agenda. However, in the near term, what gives me a lot more optimism in how we're going to expand is how there have been these agreements between the existing manufacturing companies to say, for instance, Novartis and Sanofi saying, we will sign up to manufacture Pfizer's vaccine as an example. And I want to go back and reiterate, one size doesn't fit all. The manufacturing process for a Pfizer vaccine is different from the Moderna vaccine, from the Novavax vaccine, from the AstraZeneca vaccine. So we're going to have to think this through about how do you expand the manufacturing capacity and who partners with whom. But it's doable in the mid to long term. I'm not sure it's a great solution or workable solution for the crisis in front of us right now.
Let's go to a question that bears more on vaccine distribution and access, really more so than distribution, access within the United States. Essentially, we know that there's been a lot of vaccine hesitancy in the US. How do we reconcile that mistrust and hesitancy among communities of color, and what factors might make vaccine access more equitable? We did talk about this subject a bit on our first conversation a couple of weeks ago, but Lisa, I'd like to bring that one back to you now. What do you think can be done at this point on the hesitancy piece in the United States?
Sure. It's a great question, and a couple of points that I want to make around this issue. First of all, just when thinking about how vaccine rollout is happening within the US, as we all know, it's a state-by-state determination and plan. And so I'm quite familiar with New Hampshire's plan, and they have absolutely put equity into their state rollout and plan with a focus on reducing deaths and incidences of severe disease, of course, trying to sort of keep people out of hospitals, keep people out of ICUs, and keep people from dying. So that's been a key part, at least of certainly, I would say, of some states. But in terms of the vaccine hesitancy issue, such a complicated issue, and I would actually split it into, there's going to be people who are going to be anti-vaccine no matter how much data there is. It's an ideological fixed belief, and if it's not based on science, doesn't matter how much science you produce or show people. to change those minds. But then there's people who are hesitant because these vaccines are new, the delivery model is new. And I think there are people who are waiting for more data to see and feel comfortable, and in all populations. I think we're at that point now. I mean, some of the vaccine experts say you don't breathe a sigh of relief until the first 3 million doses have been given. We've given tens of millions of doses in this country and hundreds of millions around the world. So I feel like we have good data to show that these vaccines are safe and effective. And so hopefully the people who are waiting for data will be convinced by the data, and that will help those who are hesitant for that reason. And then the last thing I would say is it does come back to what we've been talking about, which is the trust piece, right? You need to work through trusted messengers, through trusted leaders in the communities that have been hardest hit. And that's how you're going to get people to come on board and have this acceptance. It's not going to happen from a top-down approach, right? It really has to be working at the community grassroots level to bring people on board for accepting vaccines.
Great, thank you. So another question bears on the role of intellectual property and patents. Are those getting in the way of increasing vaccine production? What should the leading vaccine companies be doing to promote vaccine equity? As yet, we haven't, I don't believe, seen any examples of the major manufacturers licensing their vaccines to others to produce. Maybe that is in the offing. But Chris, why don't you start with that? Is this an issue? And can we get around it in any way other than licensing of those patented vaccines for production by others?
Yeah, I mean, in a sense, vaccines are different than small molecule drugs in that patents aren't as useful in protecting IP there, intellectual property there. It's really hard to reverse engineer vaccines. You basically need the cooperation of the manufacturer in order to produce their vaccine. So it would be hard to produce Pfizer's vaccine without Pfizer coming into your factory with the manual and helping you set it up. So but I'm not sure that's really the issue here. I think many of these manufacturers, if they could have the resources, whether it's contract manufacturers, they just can't find enough contract manufacturers to contract with to scale out their production. So I've heard, and that's basically people said, in the industry said there's only so much capacity for vaccines. You're thinking about expanding it beyond, orders of magnitude beyond what it's ever been expanded for. There's just not that many bioreactors. There's not enough adjuvant. There's not enough glass in the world, they were saying. Well, I think it actually depends on how many resources are being put to the problem. I think if you expand the resources, you can find some glass and you can find the bioreactors, you can speed things up. I think manufacturers would be willing to. I think we need to actually offer more resources and say, either as international groups or governments to say, this is a priority. We're not going to say, yeah, it's probably the case that there's no capacity around, even if we wanted to, I don't think we want to take that for the answer. We want to say, let's test it out. Let's say we're willing to put more resources and let's take bids from companies. And, if it takes a little bit more money than we've been spending for the last doses we've been spending, if we have to, spend 50% more than that per dose, that's what we have to do. And let the firms tell you that this is impossible. But I think we've seen that, some miraculous and impossible, supposedly impossible things happened. For example, developing a vaccine within a year when they said it would take 5 years. So perhaps there is this capacity to expand, but it could be, there are constraints. I mean, there are only so many bioreactors. There is only so much glass. I'm not quite sure that it's just firms are trying to, keep their secrets to themselves and not expand capacity. They'd be willing to if they got the price per dose that's been offered in the world market. It's just it is hard to find the capacity to scale up.
And as you point out, a real rate limiting factor has been the components of the vaccine and the vials, as you said. And at least now we have the Biden administration invoking the provisions of the Defense Production Act to basically prioritize manufacture and distribution of a lot of those component products. So at least insofar as the US is concerned, and the Pfizer vaccine in particular, and Moderna vaccine also, it looks like there might be more supply forthcoming because of those specific efforts to make the components of the vaccines more readily available. Is that not the case?
I believe so. I don't know. I mean, I don't know how much of a rate limiting factor that is, but it certainly can hurt. But you know, we're talking that might help the U.S. I mean, we're talking about trying to expand global capacity,
Yeah.
and you know, that's going to be a lot more than the, you know, few hundred millions of doses we're producing for the U.S.
Yep. So a related question bears on the fact that Cuba has developed effective vaccines, but it doesn't have the capacity to ramp up production. And the questioner asks, is there excess production capacity in other countries who a country like Cuba could partner with? My sense is the answer is no, but am I wrong about that, Niranjan? Is there excess vaccine production capacity around the world that could be marshaled in this crisis?
I think the short answer is no. I don't think excess vaccine capacity exists today, unused capacity, because I think, as Chris pointed out, almost all the contract manufacturing bioreactors and facilities have been locked up by the existing manufacturers. And we should also put it in perspective. The ones that have been approved are 4 or 5 of these vaccines. There's still half a dozen other manufacturers trying to get their products licensed. So in anticipation of those products coming to market, they're also locking up capacity. So this becomes a bit of a macro problem that somebody's going to have to look at. Okay, how does X get allocated to Y? What portion of A goes to Z, et cetera? And I think that's the effort that Chris is perhaps alluding to through COVAX, or somebody taking a broader macro view rather than individual manufacturers trying to do what's best interest for their production capacities.
So here's a question I'd love to hear Dr. Agnes address. This questioner asks, should vaccine distribution be prioritized based on where COVID-19 cases and deaths are highest? So therefore, where populations are at highest risk now. I'm struck by the fact that, as you said earlier, and if I understood you correctly, Rwanda has had only 250 deaths to date from COVID-19. So if we were to prioritize based on highest risk and highest case count and death rate, Rwanda would not be prioritized. How do, in your view, how do we meaningfully think through how to prioritize vaccine distribution around the world? And should we be using case counts and death rates as a proxy for who should get the vaccine first and in greatest amount?
I think that this is a way to go, but and no doubt about that. But also, you should give priority where it will be used correctly first, meaning there is a balance there. And also, I think that Lisa have worked in Tanzania. She knows what happened there. I don't see prioritizing this country, even if it's going so badly, but nobody talk about that. The president of Tanzania have started 3 days of prayer because only God can save them. No social distancing and no mask. So there are so many things entering in that, Suzanne, that there is no one answer. They are dying like crazy, anonymously, without diagnostic. So in my point of view, run there and vaccinate all of them. But in the other sense, you will not vaccinate them as much as you could. And whatever, you need to start by health professionals and community health workers. Whatever, you need to start by the elderly. Whatever, you need to start with prison and refugee camp. Whatever. So that means you need organization, and you need the country also to take charge in that logistic and dissemination. If not, you will not help the majority.
And another question I wanted to address to you, Dr. Agnes, and you mentioned earlier in your remarks that we shouldn't kid ourselves that vaccine hesitancy has been the biggest factor against vaccine use in countries such as Rwanda. But what is the vaccine hesitancy situation, if at all, in Rwanda at this point?
Vaccine hesitancy in Rwanda is not a big issue, just because the leaders in this country will never let enter something that is not safe. And people knows that. So if you come to my country and give something that people don't know you, so they will not take it. But if the leaders of this country in the health sector say it's good for you because we guarantee it, 99% of people will take it. So vaccine hesitancy is not an hesitancy against a chemical injection. It's an hesitancy vis-a-vis the leaders in place because they don't feel protected if something happened to them. They don't trust the judiciary system in case they want to complain. So vaccine hesitancy is out of the health sector. Of course, there are those crazy people, but the ordinary people trust out of the health sector, and distrust benefit to the health sector. You know, there is a great study done by Gallup and Wellcome Trust who just demonstrated that across the world.
That it's about trust in the leadership.
It's trust in systems, meaning you need to trust the people that you will be protected if you are mistreated. Man, you have so many systems that just mistreat the people. So how do you want the trust to exist?
Right. So I want to return to a point that Chris made about the long-term benefits of making these investments in vaccines and the many positive externalities, to use that economics word, that result. And this questioner basically points out the parallels to the smallpox vaccination and eradication effort, and notes that eradication of smallpox was achieved only because the least developed countries made the effort and invested the resources to make sure that the vaccine was provided, especially in very remote parts of their countries, like India, for example. Economically, the greatest financial return from smallpox eradication, however, accrued to the most developed countries. Is it time to ask for a comparable health dividend similar to the one that developed countries obtained by having all countries collaborate and provide COVID-19 vaccine equitably? It's a complicated question, but Chris, I wonder if you could take that one on.
Sure. It's clearly worth the investment to, if we could vaccinate more people in the world and eradicate COVID-19 before these novel, mutations take off and circulate around the world. But I think, now that we're in the middle of the pandemic, and, I think the rich countries are not thinking about the long term. I think they're thinking, how in the world are we going to get out of this mess? How in the world are we going to open up our economies? How in the world can we get our kids back to school? And so that, they're going to be vaccinating their grandparents, they're going to be vaccinating themselves and the kids before they're going to actually be sending these scarce doses around the world. So just realistically, I think that's going to be the case in the short term. But certainly, there should be huge investments in ramping up capacity to try to get the vaccines out there to poor countries as quickly as possible. That's certainly, I think rich countries are not going to, it's unrealistic to expect that they're going to take the doses they have and just ship them around the world. If they're going to use them for their own populations first, that's not to say that they shouldn't be investing like crazy and expanding that capacity to help people around the world. And as you say, it'll just redound to your own benefit by potentially eradicating the disease or at least quelling it.
So here's a question. The questioner says that on the last webinar in this series, a panelist mentioned that wealthy countries have driven up the cost of vaccines by the demand they generated. How much is the vaccine currently costing per dose or per person? And how much does this vary by vaccine or by country? I'm not sure that actually that was said in the last webinar. I think, and in particular in the case of the US, a lot of those prices were pre-negotiated. So it's not as if the prices have been driven up by pre-negotiated arrangements. So I think it's a little bit more complicated than the questioner suggests. That being the case, what can we say at this point about any, I suppose, open market prices for vaccines? Do we know? Niranjan and Chris, I think that's one is in your ballpark.
Chris, I'm not sure if you have data there. Last I heard, I had only heard double-digit prices in the U.S. per dose, in the realm of $15, $20 or so per dose, pre-negotiated prices. I have not heard of anything coming out of the AMC recently.
I mean, we're some work that I'm doing with a team. We're trying to estimate the social value of vaccines, and the social value of vaccines early rather than late. It's in the thousands of dollars. If you think about the global value, it's depending on how much capacity you think that we have. So the prices are between $6 and $40 a course, for a 2-dose course, and the global value is in the thousands. So there's, in a sense, the issue is not the prices. It would be worth it to the world if it's $40 a course to fund vaccine for every person on the earth, whether it's $6 a dose or $40 a dose. It's just that we don't necessarily have the capacity to supply those as quickly as we need. So part of the issue is that, why is it that we didn't invest in the capacity that we should have? In a sense, the firms don't have the incentive to build that huge capacity at risk, especially early on before they knew they were going to be successful in trials and things that would have gotten us the capacity quickly. In a sense, if you roll out the vaccine slowly or quickly, and you have a regulated price, whatever it is, for $6 or $40 a course, the firms don't really make it more profits if they give you the vaccine in January versus August, if the price is fixed. So they have more of an incentive to make sure the thing works, and to make sure that the risk is mitigated. But I think society has much more incentive. So we need to find mechanisms to try to bridge that gap there. And one of the ideas is all these bilateral contracts on dosage was probably not, quantity was not the right thing, because what you do is you say, okay, I want to buy some doses too. Well, you might just get put in the back of a long queue, and now, okay, you're getting your doses, but not for a year. So it would have been better to have contracts that say, can I buy dedicated capacity? Can we expand that capacity? And then that capacity that's dedicated to me, we can turn around and use that to supply the rest of the world. So there are clever ways to get around, but when you have a global value in the thousands and the prices are in the tens, there's a disconnect there. So I don't think that like high prices is really the problem we're facing here.
Right. So a question that I think would be great, again, to hear from Dr. Agnes, and Lisa, you may want to weigh in on this as well. So we know that the Pfizer vaccine in particular has to be stored at ultra cold storage, and the Moderna at somewhat less, but still cold storage. Dr. Agnes, you mentioned that Rwanda has the capacity now to distribute the Pfizer vaccine and meet those very cold storage capacity requirements. What does it take to do that? It is, I guess another question is, since other vaccines don't require that degree of cold storage, the AstraZeneca vaccine being a case in point, do you think other countries are going to be turning more to those other vaccines if they're not capable of developing this ultra cold storage capacity? Dr. Agnes, why don't you start, and then Lisa, let's go to you.
I just can say yes, because you don't buy things you are going to spoil. I don't know who will survive that, because it's done with the taxes. If you bring something to save me and spoil it before giving to me, and it's my taxes, I don't know how I will let you do that. So I believe that we did so because we knew that we will buy vaccine on multiple, we don't buy one type of vaccine. In this country, we will have what is available on the market and recognize, we will buy it. Pfizer was the first out and the first publicized, etc. It need infrastructure, so the country makes sure that if opportunity is there, we don't miss the opportunity because of some of a building with something in. You understand? And it was not so expensive as I was told.
And Lisa,
Yeah.
anything you want to add on that?
Yeah, I mean, I would just add, we have to be thinking about, yes, what vaccines can be used in countries, what's the infrastructure available to make these vaccines, usable and as Dr. Anya said, not spoil. So I would say we have to provide with the vaccine, whatever equipment, supplies, infrastructures necessary to ensure that they will, stay effective and be usable, and be thinking about what vaccines are coming down the pipeline that will not require such stringent storage conditions, and absolutely be thinking about how those can be used. Again, we're talking about reaching, every last person in the most remote areas of every country. We're going to need some vaccines that are going to be more user-friendly in that sense.
Great. Well, I'm afraid that we have reached to the end of our time today. I want to thank our our 4 panelists for a terrific discussion. And just to summarize what we've heard, clearly, equitable distribution of COVID vaccines is a huge and so far unmet challenge globally and within countries like the United States. And although important efforts have been undertaken to produce vaccines for poor countries and get vaccines to them, we just heard in the case of Rwanda, it is already accessing and administering the Pfizer vaccine. It's
No, sorry.
You're not
ready to
You're ready.
have
Okay.
We didn't receive the vaccine we distribute are not the Pfizer one.
Okay, I stand corrected. Thank you for clarifying that. But you're ready to. You're ready to, as soon as it arrives, and you're also ready to administer the Chinese vaccines if they arrive, and Sputnik, the Russian vaccine too. Nonetheless, as efforts clearly have to be increased to deliver these vaccines. And as we heard from all of our panelists, a big issue has been production capacity, both the overall capacity as well as accessing sufficient numbers of components to produce those vaccines. And we don't know how quickly those situations are going to resolve. There are clear examples that are better positioned even than the US to distribute vaccines. And we just heard about Rwanda as a case in point. Both with respect to the infrastructure and the underlying healthcare delivery system, but also the having community health workers and others in the environment as well. And as we heard from Lisa, until everybody has the vaccine, nobody is essentially safe. And of course, as we had a little bit of discussion in our earlier webinars with new variants about, we're not even utterly persuaded how much of a challenge those are going to be in the face of current vaccines. So it just, from an epidemiological point, as she said, we really need to assure the most equitable vaccine production possible. And as we heard from Niranjan and Chris, there are many ways to think about doing that, to expand that capacity, and frankly, lessons for future pandemics and how to get ready to do a better job the next time around. So again, thank you to all of our panelists for sharing their expertise and insights with us today, and for all of the audience in engaging in this very important One Dartmouth conversation. Please do not forget to complete the 2-minute survey that you'll be receiving at the end of today's program. Your feedback will help us enhance future programming. Do have a wonderful rest of your day. Stay safe and be well. Thanks so much.